Lisa Ramsey started her own business, Medi-Cal Consulting Services, 8 years ago, with no business plan or even a budget.
Because my business just kind of evolved. I didn't plan it, it just kind of happened. And that's really where the butterfly comes in my logo. It's because things just kind of happen.
She had worked for years at Medi-Cal offices in both Riverside and Orange counties, and also as a consultant for 2 corporate companies. She kept getting laid off and decided to go off on her own.
Because I started from my kitchen table. My kitchen table was just full of cases, and I would just work into the wee hours of the night doing casework and dealing directly with the client.
MCS assists families and healthcare professionals in understanding the ins and outs of the Medi-Cal system. Most referrals come from hospitals or nursing homes, up to 8 referral calls a day.
Maybe grandma had a stroke or mom had a heart attack. Someone fell and have broken a hip or what have you. And so these individuals now need some long-term care assistance. And maybe they're not rehabilitating as quickly as Medicare would like them to, and so they're having to now incur costs that are going to have to be paid out of their pocket.
The business is run out of her Riverside home with the help of 7 employees.
I'm very blessed to be able to give them a job, let alone pay my bills, and to be a thriving business in this down economy is just amazing.
Ramsey also hosts training sessions throughout the state to help healthcare professionals better understand the benefits available through Medi-Cal.
That they can help their families and their patients better, because there's a lot of misinformation out there about Medi-Cal and who it can help and how it can help.
Ramsey launched the nonprofit organization California Advocates for Long-Term Care Medical Assistance, which helps seniors and persons with disabilities access the resources and benefits they need.
To meet the criteria, and so many of our seniors qualify for it, and it's so beneficial in helping them get some additional help while they're still in the community, keep them from going to the nursing home.
Ramsey continues to be very involved in the daily operations of her business. After all, it's all done at home, and is finally finding time to work on that budget and business plan, but wants to find some time for herself.
I feel so blessed that I'm able to help people, and to me, working doesn't really seem like work.
In Riverside, Julianne Non, The Press Enterprise.
Hi, my name is Lisa Ramsey, and I am the founder and CEO of Medi-Cal Consulting Services. I started Medi-Cal Consulting Services from my kitchen table over 18 years ago. The experience I acquired as a consultant from 2 significant nursing home corporations and as a Medi-Cal worker in 2 counties makes me one of the leading experts in this field. I am passionate about the knowledge I've been blessed with, and I love providing in-depth Medi-Cal eligibility training and consulting services to health facilities throughout California. Holding seminars for seniors and caregivers to assist in understanding the long-term care options is one of the things that I love about being an advocate. What separates my company from others is our group of former Medi-Cal workers who have the information to survey the circumstance and answer questions. This is done at no expense to the consumer. By the end of this presentation, you should be able to identify traditional versus Magi Medi-Cal, understand how income affects share costs, describe exempt, non-exempt, and unavailable assets, as well as understand the HCBS waiver as it relates to couples in the community when one of the spouses requires nursing home level of care. Medicaid was signed into law in 1965 by President Lyndon B. Johnson and authorized Title 19 of the Social Security Act, which also produced Medicare. Medicaid does not provide health care directly to individuals. Instead, it covers the cost of their health care services. Individual states decide on who qualifies for coverage, the type of coverage, and the process of paying healthcare workers and hospitals. That is because each state is responsible to oversee and administer its own Medicaid program. The federal government matches state spending, and the matching rate varies by state from about a statutory minimum of 50% to a limit of 83%. States are not required to participate in Medicaid, although all states do. The program is the largest source of funding for health-related services for uninsured or underinsured individuals in the United States. Total Medicaid spending came to $613.5 billion in 2019, accounting for 16% of the nation's healthcare bill. The federal government paid 64.5% of the bill, while individual states paid 35.5%. Since each state is responsible for managing their version of the federal Medicaid program, they all have their own set of rules and regulations. California's Medicaid healthcare program is called Medi-Cal. Medi-Cal provides health coverage for the uninsured or underinsured throughout California, including special programs for the aged, blind, disabled, young adults and children, pregnant women, persons in a skilled nursing or intermediate care home, and persons in the breast and cervical cancer treatment program. People receiving federally funded cash assistance programs, such as CalWORKS, SSPSSI, or in-home supportive services, are also eligible. Around 13.3 million people have enrolled in Medi-Cal as of January 2018. Over the years, the Medi-Cal programs have changed and evolved. However, the noise of bad information continues. Medi-Cal can be the help we need to take care of our loved ones, but this help is often overlooked. Why is it overlooked? Why is it not utilized? For many, Medi-Cal is ignored because there's plenty of bad information. The misinformation keeps circling around and around. We have heard the inaccurate information so often and from so many sources that many potential applicants think the inaccuracies must be true. Let's quiet the noise and take a look at one of the exciting ways Medi-Cal has evolved. In 2010, President Barack Obama signed the Affordable Care Act into law and expanded the Medi-Cal program to include a new program called Modified Adjusted Gross Income, also known as MAGI Medi-Cal. The goal of the Affordable Care Act is to give more Americans access to affordable quality health insurance. This new program was created to allow coverage for those who were uninsured or underinsured. Normally, these were applicants between the ages of 21 and 64 who were not eligible for traditional Medi-Cal. Applicants qualify for MAGI Medi-Cal solely based on their income. Assets are not an eligibility factor. For those whose income is too high, they can enroll in health care plans through Covered California. Covered California is a health insurance marketplace. You can go to coveredca.com to enroll and purchase health insurance. Whether you qualify for Medi-Cal through the traditional Medi-Cal program or the MAGI Medi-Cal, it's all the same Medi-Cal program with the identical benefits. Only the qualification process is different. If you are over 64 years of age or on Medicare, you will be assessed under traditional Medi-Cal. Now, I would like to take this opportunity to put any misinformation to rest. There are no income limits to qualify for traditional Medi-Cal. Allow me to say that one more time. There are no income limits to qualify for traditional Medi-Cal. Contradictory to the misinformation in the industry, if you are currently receiving Medicare, there are no income limits to qualify for Medi-Cal. Although, depending on your income, you may have what is known as a share of cost. Share cost is calculated according to your income and the Medi-Cal program in which you qualify. Share cost is like a monthly deductible, except it is the monthly amount the Medi-Cal has decided the beneficiary is committed to pay towards their medical expenses. Share cost is based dependent on their income and the program they qualify for. On January 1st, 2024, Medi-Cal eliminated asset limits for traditional Medi-Cal. This allowed anyone 65 years of age or older or on Medicare at any age to be eligible to Medi-Cal. When the share cost is met in a month, the rest of any medical expenses will be billed to Medi-Cal. Another difference between share cost and monthly deductible is if the applicant does not have any medical expenses in a given month. They do not have to pay the share cost in that month. The share cost is paid directly to the providers who have provided the service, not to Medi-Cal. The traditional Medi-Cal program has a monthly maintenance need for a married couple in the community of $934. The spousal impoverishment provisions were meant to assist couples with care costs, but were only available when used for skilled nursing facility care. In 2017, Medi-Cal made those impoverishment provisions available to couples who wanted to remain at home through the HCBS waiver. The spousal impoverishment provisions, when applied, can make in-home care much more accessible. These spousal rules are specifically for those couples where one spouse has become ill and needs assistance. It's possible to have the Medi-Cal benefits applied to the ill spouse and the resources and income remain available to the well spouse. The HCBS waiver means the couple does not have to use up all of their resources and income to pay for the care of the ill spouse and leave the well spouse impoverished. The Home and Community-Based Services Waiver is a Medi-Cal program that in general provides assistance with skill development, respite, transportation, and other services to help support the individual and their caregiver. Section 1915C, Home and Community-Based Services Waiver, provide opportunities for Medi-Cal beneficiaries to receive services in their own home or community. Medi-Cal has really evolved with the HCBS waiver. These programs serve a variety of targeted population groups, such as people with mental illnesses, intellectual disabilities, and or physical disabilities. HCBS first became available in 1983 when Ronald Reagan signed into law and Congress passed provisions added Section 1915C to the Social Security Act, giving states the option to receive a waiver of Medicaid rules governing institutionalized care. The Supreme Court case, Olmstead v. LC, 1999, found unnecessary institutionalization to be a violation of the civil rights established by the Americans with Disabilities Act of 1990. That service be provided in the least restrictive environment. Olmstead allowed that states would be in compliance with the Americans with Disabilities Act if they could demonstrate that they had a comprehensive working plan to move people with disabilities into less restrictive settings. This provision, along with Centers for Medicare and Medicaid Services, guidance on Olmstead compliance, led to rapid adoption by the states of the HCBS waiver. Within broad federal guidelines, states can develop home and community-based services waivers to meet the needs of people who prefer to get long-term care services and supports in their home or community, rather than in an institutional setting. In 2009, nearly 1 million individuals were receiving services under Medicaid HCBS waivers. More than 800,000 people nationwide have been waiting sometimes several years. This creates gaps in services due to variation state to state. Population-based inadequacies, state-based inadequacies, and race-based inadequacies. Population-based inadequacies are when half the states spend 2 times as much money on institutional care as they do on this program. Only 8 states spend more than 50% of their federal money on HCBS. Iowa spends 10% of its money, while Washington, Minnesota, and Oregon spend 70%. Race-based inadequacies occur for many reasons. One in particular is due to the increase in admissions in communities of color and decrease in white populations. In communities with lower earning populations, access to HCBS is also limited. Prior to the implementation of this waiver, there was community-based Medi-Cal under the traditional Medi-Cal program. When a married couple needed assistance in caring for an ailing spouse, Medi-Cal only allowed a community-based maintenance need for a couple of $934 and an asset limit of $3,000 of countable assets. These stringent regulations prevented most married couples from receiving any assistance when in-home care was needed. This caused many unnecessary long-term care residents to remain in the nursing home facilities or become institutionalized. For example, if a married couple has a total of $3,000 in combined countable income, under these regulations, they would have a share cost of $2,066 a month. This would make Medi-Cal not feasible for this couple in the community. So this couple, with a combined total of $3,000 in countable income, would have a share cost of $2,066 while in the community, and if their countable assets were below $3,000. In the past, most married couples, registered domestic partners, and same-sex couples were unable to utilize the benefits through community-based Medi-Cal when one of the spouses became ill and required nursing home level of care. Either their assets were well over the limit of $3,000 of the countable asset limit, or their share cost was too high to be of any benefit. The spousal impoverishment provisions also apply to registered domestic partners. All County Welfare Directors Letter 12-36 establishes that the full array of spousal protections that are available to married, opposite-sex couples extend to the same-sex spouses and registered domestic partners. Specifically, the rules regarding the amount of income and property a community spouse may retain when their spouse becomes institutionalized. Medi-Cal becomes necessary when one of the spouses, registered domestic partners, or same-sex couples becomes ill and requires nursing home level of care, also known as custodial care. Medi-Cal has a program called long-term care. When a Medi-Cal applicant enters a skilled nursing facility, long-term care rules apply to determine the month of long-term care status, who is in the Medi-Cal family budget unit, and how to treat the income, property, and proper budgeting. For recognized couples with one spouse in long-term care, there are two sets of rules: the Medicare Catastrophic Coverage Act and the Community Property Income Rules. Which rules apply depends on the date the individual entered the long-term care facility and applied for Medi-Cal. These regulations define new terms such as community spouse, institutionalized spouse, continuous period of institutionalization, and allow the institutionalized spouse to allocate income and property to the community spouse at home without considering the state's community property and income laws. Assembly Bill 641 allows counties to implement the Medicare Catastrophic Coverage Act rules to same-sex spouses and registered domestic partners, effective January 1st, 2012. Medi-Cal applicants who entered a long-term care facility prior to September 30th, 1989, fall under the state's Equal Division of Community Property and Income rules. Under these rules, terms such as long-term care status, separate and community property, and spouse at home all apply. Long-term care Medi-Cal has specific guidelines which include the spousal impoverishment rules. The Medi-Cal spousal impoverishment rules are designed to prevent the impoverishment of one spouse when the other spouse applies for long-term care Medi-Cal or home and community-based services. The expense of nursing home care, which can range from $7,000 to $10,000 a month or more, can rapidly deplete the lifetime savings of elderly couples. In 1988, Congress enacted provisions to prevent what has come to be known as spousal impoverishment, leaving the spouse who is still living at home in the community with little or no income or resources. These provisions help ensure that this situation will not occur and that community spouses are able to live out their lives with independence and dignity. Under the Medicaid spousal impoverishment provisions, a certain amount of the couple's combined resources is protected for the spouse living in the community. Depending on how much of their own income the community spouse actually has, a certain amount of income belonging to the spouse in the institution can also be set aside for the community spouse's use. This means that certain individuals can be eligible for Medi-Cal with more generous income and asset limits, enabling them to access services without depleting all of their resources, and this will ensure share costs goes down. Federal law specifies that certain programs be considered before others when Medi-Cal eligibility is determined or redetermined as they are annually. At application, annual renewal, or when a change of circumstances is reported, the applicant's Medi-Cal eligibility must be determined by progressing through the Medi-Cal hierarchy outlined in Al County Welfare's Director Letter 17-03. The applicant may not be eligible for some programs after the screening. Eligibility must be determined for each program where the applicant has potential Medi-Cal eligibility. When an applicant is eligible for more than one Medi-Cal program and one is more beneficial, then the individual should be placed in the Medi-Cal program that is most beneficial for them, unless the individual requests otherwise. Additionally, other home community-based services individuals can transfer property to themselves. Under these spousal impoverishment rules, Medi-Cal allows the spouse, registered domestic partner, same-sex couple who is not receiving Medi-Cal, referring to them as the well spouse. The well spouse is allowed to retain additional assets and income without compromising the eligibility for the ill spouse. All County Welfare Directors Letter 17-25 requires that the county eligibility worker to apply the spousal impoverishment provisions in the first month when both of the following exist. The request for either home community-based services or in-home supportive services has been made, and the individual meets a nursing facility level of care as determined by a doctor or an assessment by the home community-based services waiver or program. The date that both these criteria are met is known as the applicable application date for spousal impoverishment provisions. The minimum resource allowance is intended to protect these couples that have limited resources. Remember, this amount can be increased. In addition to the community spouse resource allowance, the well spouse is allowed to retain additional income without having to pay all of their income towards the share cost. The well spouse is allowed to retain all of their income. Their income is only verified at time of application to assess if their income is below the minimum monthly maintenance needs allowance. If their income is below the minimum monthly maintenance needs allowance, then they may receive an allocation from the ill spouse's income to bring their income up to that amount. If the well spouse's income exceeds the minimum monthly maintenance needs allowance, they will not be eligible for any allocation of their spouse's income. The well spouse can have unlimited income, and they will not be required to give up any of their income ever. These rules allow for the well spouse to retain the community assets and income so they don't become impoverished while their ill spouse is receiving the care they now require. In most cases, once the ill spouse becomes well enough to go home, they were unable to continue the Medi-Cal benefits in the community due to the strict guidelines imposed on community-based applicants. Remember in my previous example, the monthly maintenance needs for an elderly couple in the community under the Age, Blind, and Disabled Traditional Medi-Cal program is $934. So once Juliet was well enough to go home, the Medi-Cal share cost would increase to $2,066, making the benefits not feasible. In November of 2017, Medi-Cal issued All County Welfare Directors Letter 17-25 that implemented a waiver program called Home and Community-Based Services Program. Married couples in the community can utilize the spousal impoverishment rules normally reserved only for long-term care applicants and qualify for Medi-Cal while in the community. In most cases, they would be eligible with a zero share cost. These rulings make life-changing services possible to married couples in the community, such as in-home supportive services and the assisted living waiver program. For more information on these programs, check out Medi-Cal Consulting Services YouTube channel. There's a number of videos that are helpful and informative. Now, as you can see, the home community-based services benefits couples in the community so that when the eligible spouse goes in and out of long-term care, the level of care would not change and the couple will not be as affected as they were prior to the implementation of these rulings. In order for an ill spouse to be deemed to be at nursing home level of care, a doctor's authorization is required. You're probably now wondering, how can people who need long-term care level of care apply for this program? They're going to need to fill out an application at their local Medi-Cal office and provide evidence of their developmental disability, an appropriate level of need for services, be determined eligible for services, have an appropriate living situation, and other information is also required. They can also have trained agencies such as Medi-Cal Consulting Services assisting them with becoming eligible. If the applicant has not yet received a needs assessment by the Waiver Program or IHSS, the county eligibility worker must obtain documentation that the ill spouse meets the nursing facility level of care requirement through the DACS MC 604 MDV. This doctor's verification form is required in order to apply the spousal impoverishment provisions. If a doctor's verification is necessary, counties must provide the form to the applicant as soon as the request for IHSS or HCBS is made. The spousal impoverishment provisions must be applied to home community-based services spouses who request IHSS and provide a completed doctor's verification form, indicating a need for nursing facility level of care for at least 30 consecutive days. Any IHSS request is adequate. Likewise, any request for home community-based services must trigger the doctor's verification process. The date the doctor determines the ill spouse needs nursing home level of care determines when the applicant will be eligible for services under the waiver program. The MC 604 MDV form and the needs assessment serve different functions and are not interchangeable. Both may be required for an individual requesting in-home care, depending on the timing of the request for services and their individual circumstances. The purpose of the doctor's verification form is to verify that the individual requires a nursing facility level of care for at least 30 consecutive days in the absence of in-home care and support services, and typically will be used in cases where there has not yet been a needs assessment. The doctor's verification form is completed by a medical doctor using their medical judgment as to whether nursing facility level of care is needed and the date when it was first needed by the individual. It is one of the two criteria to start the application for spousal impoverishment provisions. In contrast, the needs assessment is completed at the individual's home, hospital, or rehabilitation center, and is conducted by a social worker or eligibility screener who makes a clinical determination based on a functional index scale. As stated in All County Welfare Directors Letter 17-25, once determined eligible using the spousal impoverishment provisions, the HCBS spouse remains eligible, aside from a change in circumstance, unless and until the request for HCBS is denied. The request may be denied because the individual did not meet the clinical standard for the waiver. Once this fully executed form has been submitted to Medi-Cal, along with the application for Medi-Cal benefits, the county eligibility worker is mandated to process the application within 45 days. Although this program has been available here in California since 2017, many counties struggle in understanding how to administer the benefits. If you need assistance in getting your county to process these benefits, please reach out to Medi-Cal Consulting Services for assistance in resolving the issue. I have a little extra time to share with you two additional rulings that are often used to assist long-term care residents with the cost of needed care or services. The first is a program called Hunt vs. Kaiser. You may have heard about it, as it's been around since 1989. Hunt vs. Kaiser allows beneficiaries to use old, unpaid medical bills for which the beneficiary is still legally responsible, to reduce the monthly Medi-Cal share cost. The share cost will be changed to reflect the cost of the outstanding balance. This is not automatic and should be discussed with the eligibility worker at the time of application or any time thereafter. If you have difficulties in getting your request processed, please reach out to Medi-Cal Consulting Services for assistance. This can be helpful when you have a resident who has come in and out of your facility and they have an outstanding balance. For example, the resident left owing $10,000. They have a $2,000 share cost and are now back in long-term care. Once Medi-Cal has processed the Hunt vs. Kaiser request, the resident's share costs will be zeroed out for 5 consecutive months to cover the outstanding balance of $10,000. Lastly, another program available to assist long-term care residents with needed services is called Johnson vs. Rank. Under the Johnson vs. Rank settlement, beneficiaries may use their share cost to pay for medically necessary supplies, equipment, or services not covered under the Medi-Cal program. A doctor's order is required to show medical necessity and must be put in the beneficiary's record at the facility. This prescription must be a part of the physician's plan of care. After a copy of the prescription and the bill is presented to the facility will deduct their fee from that month's share of cost and bill the resident for the remaining share of cost, if needed. This is extremely helpful in covering the cost of certain items like eyeglasses, dentures, or hearing aids when they are misplaced. This can also be used to pay for the cost of specialized equipment needed to offer a better quality of life for the resident. Each waiver has its own focus and services, and an individual may be a better fit under one waiver than another. At annual renewal, the HCBS spouse, community spouse, beneficiary, representative, administrator, or care coordinator need only confirm continued HCBS participation, just as an institutionalized spouse would confirm continued institutionalization on their renewal forms. As long as the period of HCBS participation or institutionalization continues, there is no need to re-verify the nursing facility level of care. This should give you a better understanding of how the HCBS waiver program allows a married couple, registered domestic partner, or same-sex couples to remain in the community and not become institutionalized in a nursing home facility.